Welcome back, guys. In part 2 of this video, let's mainly concentrate on the pathophysiology of pregnancy-induced hypertension. Guys, please concentrate here. See this area, okay, which I am highlighting here. See these arteries. See, these are maternal spiral arterioles. Okay, these areas which I am marking in red color, okay, which I am circling in red color, these arteries, whatever you are seeing, they are maternal spiral arterioles. See, physiologically during pregnancy, what actually happens is the cytotrophoblast from this area, okay, the extravillous cytotrophoblast will invade the maternal spiral arterioles. Okay, what happens? See, this cytotrophoblast, when it invades the maternal spiral arterioles, it replaces, okay, the spiral arteriolar endothelial lining as well as the muscular lining of those spiral arterioles will be replaced by the cytotrophoblast. This is known as cytotrophoblastic invasion or simply trophoblastic invasion, which happens physiologically during normal pregnancy. I am repeating, guys, please concentrate. The entire pathophysiology of pregnancy-induced hypertension or preeclampsia revolves around this. Okay, it's a placental pathology. What exactly happens? In a normal pregnancy, the spiral arterioles are invaded by the cytotrophoblast. Now, this cytotrophoblast, when it invades the maternal spiral arterioles, now this cytotrophoblast is going to replace the endothelial lining. It also replaces the muscular lining. So that what happens? Initially, these spiral arterioles are high resistant vessels, which means the diameter of these spiral arterioles is very narrow. They are high resistant vessels. Now, whenever the endothelial lining and the muscular lining is replaced, they are converted to low resistant vessels or low resistant channels, so that more blood will be coming to the placenta. That's what is desired. That's what the baby wants. Okay. So, what actually happens? Please concentrate. The cytotrophoblast is going to invade the maternal spiral arterioles, and that process is known as a trophoblastic invasion, which happens physiologically. Because of this, there is this vascular remodeling is happening. Okay, this process is known as vascular remodeling, where the endothelial lining and the muscular linings are replaced by the cytotrophoblast. So that what happens ultimately, the spiral arterioles, they become more widened up, they become more opened up, so that they become low resistance channels. Low resistance means more blood is coming to the placenta. This is what happens normally. But in pregnancy-induced hypertension or preeclampsia, what exactly happens? Guys, what exactly happens is the main problem or the main issue here is incomplete trophoblastic invasion. The trophoblastic invasion doesn't happen normally. There is abnormality in the trophoblastic invasion. Because of the abnormality, there is a defective spiral arteriolar remodeling. Okay, the remodeling hasn't occurred properly. So that what happens? The spiral arteries, instead of becoming a low resistant channels or low resistant vessels, now they are still remaining as a high resistant channels. So that what happens, sir? If they are high resistant channels, do you think that a good amount of blood is going to come to the placenta? Definitely not. So that causes placental ischemia or placental insufficiency. No good amount of blood is coming there. So what happens? Usually the placental size will become small and pale in color. See, my question is there is insufficiency or not? Yes, there is insufficiency of blood that's coming here, and there is ischemia. Ischemia leads to hypoxia. So that what happens here is release of inflammatory mediators. Because of these ischemic conditions, there is a release of the inflammatory mediators by the placenta. Okay, so placenta is going to release the inflammatory mediators. Because of the release of this inflammatory mediators, what happens? See, these inflammatory mediators will cause dysfunction to the endothelium. They cause damage to the endothelium. So whenever endothelium is damaged, what happens? A lot of problems are going to come by, because all your organs are supplied by the blood vessels, and all those blood vessels are lined by endothelial lining. So because of this inflammatory mediators, there is dysfunction of the endothelium. Endothelial dysfunction is the key feature. I am repeating. For all the problems in pregnancy-induced hypertension or preeclampsia, the main core problem is endothelial dysfunction. If endothelial dysfunction is there in kidneys, kidneys will be damaged. If the endothelial dysfunction is there in the liver, that can cause hepatic necrosis, that can cause hepatic thrombosis, all this stuff. Okay, so the main key center is endothelial dysfunction. Now, what exactly you are seeing in this image is, see, in healthy pregnancy, see this spiral arterioles, this is the spiral arteriole. This spiral arteriole is more widened up so that more blood, the more maternal blood is coming into the intervillous space. But see, in preeclampsia, what exactly is happening when compared to here, okay, when compared to here, the blood vessels, the spiral arterioles are more narrower. Okay, why? There is incomplete trophoblastic invasion. Because of that, the vessels are still remains as a high resistant channels. They are not converted into low resistant blood vessels. Okay, so because of that, we have already seen there is this placental ischemia, and that causes production of the inflammatory mediators, and that inflammatory mediators are the ones which are going to cause the endothelial damage. Now, please see here, this is a very important slide which I am directly quoting it from the more authenticated sources. See, it's a role of systemic endothelial dysfunction. Okay, the role of systemic endothelial dysfunction. I have already said you that endothelial dysfunction is the key. See, all clinical features of preeclampsia can be explained by clinical responses to generalized endothelial dysfunction. See, all the key clinical features are explained because of endothelial dysfunction. It's the endothelial dysfunction which leads to the clinical features. For example, hypertension. We all know that in preeclampsia there is hypertension. Why there is hypertension, sir? You can ask me why. See, hypertension is a result from disturbed endothelial control of vascular tone. We all know that endothelium, it maintains the vascular tone. Endothelium produces the nitric oxide, and that nitric oxide can cause dilation of the blood vessels. So whenever there is endothelial dysfunction, do you think that nitric oxide is going to be produced? No. So that causes vasospasm, and that causes hypertension. So hypertension is a result of endothelial dysfunction. And please concentrate here, proteinuria and edema. In pregnancy-induced hypertension, yes, there is proteinuria and edema. Why there is this proteinuria and edema? Proteinuria and edema are caused by increased vascular permeability. See, these inflammatory mediators, we have already studied in the patho, that whenever there is acute inflammation, the inflammatory mediators, they are going to cause the endothelial, endothelial separation, or the endothelial cell retraction and all the stuff, so that the vessels will become more leaky. The same thing is happening here. Because of this endothelial, because of the inflammatory mediators, the blood vessels, they are becoming more permeable, or they become more leaky. Whenever they are more leaky, the plasma from the blood vessels is going to come into the interstitial space or the third space, that leads to edema. So preeclamptic patient, they can present with edema. Yes, definitely they can present with edema. And why there is proteinuria? See, endothelial damage can occur not only in the placental blood vessels, it can happen anywhere in the body of the mother. If the endothelial dysfunction is happening in the kidneys of the mother, what happens? There will be loss of proteins in the urine. So mother is losing her proteins in the urine, that leads to proteinuria. Because of the increased vascular permeability, there is a leakage of proteins and leakage of the plasma into the third space, that causes edema. Okay. So again I am repeating, proteinuria and edema, they are mainly because of increased vascular permeability. And coagulopathy, a patient with preeclampsia, they can go into the coagulopathy. It is result of abnormal endothelial expression of procoagulants. Because of the damaged endothelial cells, these damaged endothelial cells, they are going to express the procoagulants, and that can favor the coagulation cascade to happen. That leads to coagulopathy. Okay, and we have also seen that headache, seizures and visual symptoms, epigastric pain and fetal growth restriction, all can be seen. Okay, headache can be there, visual disturbances. Why all this stuff? All this stuff is because of endothelial dysfunction in the respective organs. Okay, See, all these sequelae are because of the endothelial dysfunction in the vasculature of the target organs. Okay, in particular organs, the endothelium is getting damaged. That leads to specific symptoms. Okay, so at the end of the day, the key important point I want to put into your mind is it is the endothelial dysfunction because of the placental insufficiency. Okay, placental insufficiency producing the inflammatory mediators. Those inflammatory mediators are damaging the endothelium, and that endothelial damage is causing all the symptoms. Okay, now let's talk about the main core points. See, we have already seen that because of the incomplete trophoblastic invasion, there is a defective spiral artery remodeling, and that causes the spiral arteries to remain as a high resistant channels, and that leads to placental ischemia, and that leads to the release of inflammatory mediators. And because of the production of inflammatory mediators, there is this endothelial dysfunction. We have seen still here. Okay, till here we have already seen. See, because of the endothelial dysfunction, there is vasospasm. Yes, endothelial dysfunction causes the vasospasm. True. Because of the vasospasm, what happens? There is hypertension. Yes, why a female with preeclampsia is hypertensive? Because of the vasospasm, important. And because of the vasospasm, there is a very much decreased blood going to the liver, and that can cause hepatic necrosis, and that hepatic necrosis can manifest as right hypochondriac pain or epigastric pain. Okay, true. And this vasospasm can decrease the amount of blood going to the retina, and that can cause retinal ischemia, and that can present as abnormality in the vision or blurring of the vision. So all these are because of the vasospasm. These are the symptoms of vasospasm. And also remember, I have already said you that because of the endothelial dysfunction, the vessels will become more leaky. Okay, these are leaky capillaries. So whenever the capillaries are leaking, whenever the plasma is going into the organs and into the third space, that can lead to edema. And if this same thing is happening in the lungs, that can lead to pulmonary edema. If it's happening in the cerebral vasculature, that can cause cerebral edema. Okay, and also very important point, the glomerular capillaries, whenever they become more leaky, proteins are going to lose. That can cause a proteinuria. Okay, and also very important point. This is a very it's a key point to it's a take home point. See, in pregnancy induced hypertension, they can ask you that hemoconcentration is going to occur or hemodilution is going to occur. Actually, during pregnancy, there is physiological hemodilution which happens. But please concentrate here, because of the movement of the plasma into the third space or into the interstitial space. What happens? Just think logically. If the plasma is moving out, the blood will become more concentrated. Okay. See, the capillaries are leaky capillaries. Plasma is coming out of the blood vessels. So that what happens? Inside the blood vessels, the blood is becoming more concentrated. So hemoconcentration will occur in pregnancy-induced hypertension or preeclampsia. So because of this hemoconcentration, there is a less perfusion to the tissues. Okay, so the blood is getting more concentrated. Okay, it's not just the physiological hemodilution. If there is a hemodilution, there is more blood volume and more blood will be going to the tissues. Same happens opposite. If there is hemoconcentration, there is less amount of blood is going to the tissues. If less amount of blood is going to the tissues, there will be hypoxia in the tissues. Okay, so in the brain, this hypoxic conditions can lead to convulsions, that is eclampsia. So why eclampsia can happen? Eclampsia can happen because of this reason. So eclampsia is because of hypoxia. Convulsions are because of the hypoxia. Okay, so that's a very important MCQ. And hypoxia is because of ischemia, means less blood flow. Okay, so in brain, it can present as convulsions. The same thing happens in the kidney. If less amount of blood is going to the kidneys, that can lead to decreased GFR. Okay, decrease glomerular filtration rate. If less amount of blood is getting filtered, more waste products are getting retained in the body. So blood urea nitrogen and serum creatinine are going to increase in the body. Okay, in pregnancy-induced hypertension, there is increased serum creatinine levels and increased serum blood urea nitrogen levels. True. And the same way, whenever there is less blood going to the fetus, yes, we have seen that these spiral arterioles, they are now high resistant channels. No good amount of blood is going there. So what happens is intrauterine growth retardation. Intrauterine growth retardation can occur. Okay, less blood is going to the fetus, so intrauterine growth retardation. Also remember, if less blood is going to the fetus, automatically less amount of blood is going to the fetal kidneys also. So whenever less amount of blood is going to the fetal kidneys, the baby can have oligohydramnios. Okay, so less amount of blood is going to the fetus, automatically less amount of blood is going to the fetal kidneys, less amount of GFR will be there by the fetal kidneys, so very little urine output will be there, so that can manifest as oligohydramnios. Okay, so and also because of the endothelial dysfunction, there can be thrombosis also. We know that endothelial dysfunction can lead to thrombosis. So everything revolves around endothelial dysfunction. Now please concentrate in this image here. See, we have already seen these are the maternal spiral arterioles. Okay, now just tell me, what is the state of this blood vessels? These are under vasospasm. Okay, these are under vasospasm and these are very fragile blood vessels. Okay, there is hypertension and that hypertension can cause breakage of these blood vessels. Okay, these blood vessels can easily be damaged. So that causes clot formation here. Okay, that causes bleeding here. Okay, in this region there can be bleeding because of the rupture of those maternal spiral arterioles because of the too much amount of hypertension, and that bleeding can lead to separation of placenta. Okay, see, if in all this region, if blood is getting accumulated over here, and that can lead to separation of the placenta. So a very important point, a take home point is that pregnancy induced hypertension is a risk factor for abruptio placenta. Okay, that's a very important point. It's a risk for abruptio placenta. And very important point is that diuretics are contraindicated in pregnancy induced hypertension. True or not? Yes. See, actually, if you are thinking logically, see, this patient is a hypertensive patient. Now, how we usually treat hypertension? Usually we treat hypertension by using diuretics. Diuretics are antihypertensive drugs. So can we use this diuretics to treat this hypertension? Definitely not. See, in pregnancy induced hypertension, diuretics are contraindicated. Very important MCQ. Why? Because already here there is hemoconcentration. Actually, pregnancy demands physiological hemodilution. Already here there is hemoconcentration. Okay, now further if you give diuretics to treat the hypertension, what exactly diuretics do? Diuretics remove the water from the body. Okay, it increases the urination so that more water will be removed, so that more hemoconcentration can occur. Okay, so already she is suffering with the hemoconcentration, and this hemoconcentration is causing decreased perfusion to the multiple organs. That's leading to multi-organ failure actually. So never give diuretics. If you give diuretics, you are actually killing the patient because more hemoconcentration can occur. So diuretics are contraindicated, and pregnancy induced hypertension is a risk for placental abruption. Very important MCQ. Okay, here also you can clearly see that, see, it's all the placental ischemia. Start from here. Okay, it's a placental ischemia which ultimately leads to endothelial dysfunction. It's the endothelial dysfunction which causes the multi-organ failure. That's the take home point. And here also you can clearly see this is a normal pregnancy. In normal pregnancy, the maternal spiral arterioles are wide open. Okay, they are low resistant channels. But here in preeclampsia, you can very clearly appreciate that these vessels are high resistant channels. Okay, so that's the one leading to the placental ischemia and all the downgoing cascade of events. Okay, see, if someone asks you what's the most common organ to be affected in pregnancy induced hypertension, in exam if they ask you most common organ to be affected in pregnancy induced hypertension, it's the kidneys. And if you take a histopathological slide, what you can see in the kidneys is glomeruloendotheliosis. Okay, see, it's the endothelium which is getting affected, right? So glomerular endothelium is getting affected. That's what you can see in the histopathology. The most characteristic histological finding, histopath finding, it is a glomeruloendotheliosis, and the most common organ which is getting affected in the pregnancy induced hypertension, it's the kidneys. Hope you understand the pathophysiology. In the next video, we are going to discuss how to manage pregnancy-induced hypertension and how to manage eclampsia. Okay, thank you.